welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am Sherry Binns, and I'm the Patient Healthcare Liaison for MS Focus, and I'm joined tonight by Dr. Fred Foley, who will be speaking to us about what to do about anxiety and depression. After Dr. Foley's presentation, we will open it up for your questions. Dr. Foley received his Ph.D. in clinical psychology from Fordham University and is a professor emeritus of psychology at Yeshiva University in the Bronx. He's also the director of neuropsychology at Holy Name MS Center at Holy Name Medical Center, a publisher of numerous scientific articles. His translational research on depression and immune system dysregulation took an award, and he has served on the Medical Advisory Board of the National MS Society and as president of the Consortium of MS Centers, where an award in his name is given annually to an individual whose contributions advance the treatment of neuropsychiatric disorders in MS. He's been a recipient of several research and educational grants and consults with organizations in both the public and the private sectors on MS-related topics. Now, I'm delighted to welcome Dr. Foley.
Thank you so much for that very kind introduction, Sherry. I want to thank you and thank the MS Foundation and MS Focus for inviting me here this evening to get to spend a little bit of time with you. And I hope we can have a little quality time together tonight. So, and I'm going to be talking to you about a topic that, as we were saying before the conference started, a lot of people don't talk about enough, about depression, anxiety, and emotional health in MS. So if you kind of happen to be depressed or anxious, the most important thing that you can get out of this webinar tonight is to talk about it with your healthcare providers. And, you know, if they slough it off, you know, kind of insist that you get help with these symptoms. So I want you all to be your own advocates, you know, particularly in the area of mental health and physical health, of course, where these kind of issues and concerns are frequently neglected, you know, by healthcare providers. Okay, I have some slides to show you. Here it is. Okay, so tonight we're going to be talking about the different kinds of emotional disorders that can occur in MS. How frequently do they occur in MS as opposed to the general population? And sometimes it's hard to diagnose these because sometimes symptoms of things like depression can overlap with symptoms of MS. If I asked you to show me by raising your hands, how many of you have ever experienced fatigue or significant MS fatigue, the majority of you would raise your hands. Well, that's also a symptom. Okay, I see some hands raised. It's also a symptom of depression. So, and sleep disturbance is common in MS, but it's also common in depression. So because there's overlap with symptoms between depression and MS, it's sometimes hard to diagnose. And that's why I want you to all complain about it to your healthcare providers, you know, and get some help with this. So these are some of the factors that are contributing to kind of emotional disorders in MS. There are genetic and psychosocial risk factors that are associated with depression and anxiety in the general population and also in persons with MS. So sometimes inflammation in the central nervous system triggers depression. And as we know, MS is a condition where there is inflammation in the central nervous system. So that inflammation can directly cause mood changes. And also we know that about 47% of the variance of depression in MS is associated with structural brain lesions, in certain areas of the central nervous system. Now, listen, even if depression is caused by brain lesions, it can still be effectively treated. So I just want to make that point right up front. We're going to talk about how to do that. Depression can be, or anxiety can be a response to chronic illness. MS-related pain, fatigue, or cognitive changes can all contribute towards mood changes. And some symptomatic MS treatments, not disease-modifying therapies. For example, high-dose corticosteroids in someone who is genetically vulnerable can induce mood swings that could be significant. Okay, when we look at the lifetime prevalence rates of major depressive disorder, and major depressive disorder is a severe depression. It's, when you kind of have lost the luster for life, nothing seems to matter to you. You feel sad most of the day, nearly every day, for week after week on end. You've lost interest in the things that usually you would be interested in. And so that's kind of one of the most severe depressive disorders. And the lifetime prevalence rates, that is, your risk of getting it, is somewhere between 36 and 54%, as opposed to 16% in the general population. So having MS is associated with much higher rates of that, and of anxiety disorders, and something they call adjustment disorders. An adjustment disorder is an emotional response to a traumatizing event. For example, if you have an MS exacerbation, that could be very upsetting, and lead to what they call a temporary adjustment disorder while you're sorting things out and kind of dealing with the consequences of that exacerbation. The basic, there's a lot of figures on this slide, but I'm going to help you out and tell you the most important thing. Basically, 45% of patients in a national survey, and it was a large survey, there was over 8,000 participants in this survey, 45% who did not ever receive a diagnosis of depression actually had scores that was consistent with major depression. So it's, a lot of times doctors don't ask about depression. And, I feel bad for neurologists. They have so much to do in one visit. They got to kind of decide whether to send you for an MRI. They have to see if your DMT is working. They have to deal with, the various symptoms that you're experiencing, try to help with it. They have to pack in a lot. So I don't want to throw the neurologists under the bus for not asking about depression. I want to empower you to ask about it. And if you're not feeling good emotionally, to then take the reins and do something about it. Okay, and anxiety disorders in MS are also much higher than in the general population. And about between 22 and 44% of persons with MS will develop an anxiety disorder. An anxiety disorder is when you feel very anxious or fearful, much of the time. So, and there are different types of them. Also, bipolar disorder, which is another type of depression, kind of increases slightly over time in persons with MS. And there seems to be more, even though it's a relatively rare depression, there seems to be more of it in MS than in the general population. There's another emotional disorder that's sometimes confusing to patients, and it's called pseudobulbar affect. And pseudobulbar affect is characterized by brief, exaggerated, and uncontrollable expressions of laughing or crying that aren't matched by your inner mood. So in other words, you don't feel happy, yet you burst out laughing, or you don't feel sad inside and you burst out crying. So, so there've been a number of epidemiology studies on this in MS, and found that about 11% of persons with MS are diagnosed with a pseudobulbar affect. Fortunately, there's a treatment for it that is FDA approved. So, if you kind of you notice that your inner mood doesn't match your outer expression of your emotions, talk to your healthcare provider about it, because there is an FDA approved medicine that treats that. So let's talk about other treatments for depression in people with MS. Well, there's antidepressant medications, and there are more of them kind of coming out every single day. In my experience, I found that persons with MS sometimes need higher doses of antidepressants. So if your neurologist is putting you on a low dose, or your healthcare provider, and it's not working for you, go back and complain about it. Let them know it's not working for you, that you still feel depressed. And sometimes, healthcare providers that are not psychiatrists or psychiatric nurse practitioners are a little reticent about prescribing, the higher end doses of these meds. So if that's the case, you might want to see a specialist, like a psychiatrist or a psychiatric nurse practitioner who can, who are specialists in this area and can kind of give you medicines at the appropriate dosage to help remediate your symptoms. So there's also psychotherapy. And I'm going to talk to you and give you examples of a type of psychotherapy that has the best support in the literature for persons with MS. It's called cognitive behavioral psychotherapy. And there have been randomized clinical trials of this in MS that have shown that it works either in person, via telephone, or via telehealth. So if I had MS and I was depressed and I had to choose a psychotherapist, I would ask them, do you know how to do cognitive behavioral psychotherapy? Because it's just best supported in the literature on helping people with MS. There is some data that is coming out that shows that aerobic exercise can exert beneficial effects on mood. So there have been quite a few studies of this in the general population on the use of aerobic exercise for the treatment of depression. And there's studies being done on MS and this, and preliminarily, it looks like it improves mood in MS. So if you're a couch potato by nature, you might want to consult with your healthcare team and physical therapists so that you can kind of develop a little bit of an aerobic exercise program that is safe and is not going to interact negatively with your MS symptoms. So I always advise people, if they're going to start exercising and they have MS, get a professional consult first to make sure you're going to do it well, and make sure you're going to do it in a way that will be maximally beneficial to you. Another treatment being tried is something called transcranial magnetic stimulation, which basically stimulates the brain, but there's really kind of no evidence on that as of yet, whether that's helpful in MS. There is some evidence in the general population that's helpful for depression. So in terms of anxiety disorders and the treatment of anxiety disorders, there's less evidence than there is for depression. There's a lot of evidence that cognitive behavioral psychotherapy helps depression in persons with MS. However, there's some things that have been tried in clinical trials, such as something called mindfulness-based stress reduction, reduced both anxiety symptoms and depressive symptoms. Cognitive behavior therapy, combined with relaxation training, has been found to reduce both anxiety and depression in randomized clinical trials. And internet-delivered behavioral interventions to increase lifestyle physical activity, here we're getting back to that, getting more physical activity in, has been found to significantly decrease anxiety in persons with MS. And on top of all that, biofeedback in one study, when it was added to kind of relaxation training, mindfulness training kind of helped decrease anxiety in persons with multiple sclerosis. So people ask me all the time, what is cognitive behavioral therapy anyway? And so one of the things that cognitive behavioral therapy does, and I'm going to give you some examples of it, is it leads to increases in people using coping strategies in MS. In our studies, we found that that increase in coping strategies, to cope with their mood and to cope with their life problems, is associated with that decrease in anxiety and decrease in depression. So, and in our studies, we found that, increases in coping were highly correlated with improvements in mood, lower anxiety and depression, better communication, better emotional connections, and better marital satisfaction. So let me explain a little bit about this cognitive behavior psychotherapy stuff. So let's start with a cognitive behavioral definition of anxiety. Have any of you ever experienced a moment's anxiety in your lives? So we're all human beings. We all experience anxiety, but sometimes in MS, the anxiety can become so severe that it can significantly interfere with your quality of life. So, and if you think about what anxiety is, it's really about your expectations. Even if it's biologically kind of sourced, it still is going to channel your brain to think that something's going to happen and it's going to be bad. So anxiety is it's about your expectations. It's the expectation that something's going to happen and it's going to be bad. And as soon as you kind of dwell on that, you're going to feel anxious or fearful or nervous. And when people get anxious, their behavior changes as well. It's, they kind of sometimes withdraw a little or sometimes become irritable. I'm sure none of you have ever been irritable, in your lives. But nonetheless, that can be accompanied by either anxiety or depression. And there are physical changes associated with it, increased muscle tension, shallow breathing. So, in other words, anxiety is always about the future. It's not about the present moment. It's an expectation that something's going to happen and it's going to be bad. One patient, when he had an exacerbation, kind of called me up and said, I need a booster session. I would see him periodically. And I said, okay, come on in. I said, okay, what are your expectations associated with this exacerbation? And he said, it's all going to be downhill now. That's it. I'm never going to get out of this exacerbation. I'm going to go straight downhill. And he had maybe half a dozen other exacerbations where he thought the same thing, and none of that happened. So I just kind of asked him if he could, try to kind of remember that his experience was that, he didn't go straight downhill and that was the end, that the exacerbations remitted, at least mostly remitted. And so to hold on to that thought and to stay in the present moment. And so that's a very important technique. It's called mindfulness. And we teach people how to be mindful, which is really focusing completely on the present moment. And we teach them to do that by focusing on your senses. For example, how comfortable is the chair you're sitting in right now? Feel the pressure of it on your body. Notice the temperature in the room. Take a slow, deep breath. Are there any aromas in the room? What are you hearing, as you're listening right now, besides the sound of my voice? Are there noises in your room that you're listening to? So focusing on all of your senses. What do you see? Look around the room that you're in right now and really notice the colors and the shapes and the details of the things in your room. If you do that intensely, I'll bet you'll see things you never saw before. So this kind of mindfulness approach, there's lots and lots of apps for mindfulness that you can download and get to practice this technique. So I encourage people when they're going to learn it to practice at their next meal. So, really focus on the way your food is arranged on the plate, the colors and textures. Take a slow, deep breath, really inhale the aromas of the food, kind of focus on the movements that you're making towards the food to pick it up, and then saturate yourself with the flavors of it. Inhale just before you kind of put it in your mouth. Maximize the aromas associated with it. So if you're doing that, you can't be worrying about the future. So it's just one example of mindfulness, and one of the ways we start training people in it, because I think it's easier to do when people are kind of having a meal. So try it. So as a professor, by the way, I'm warning you, I like to give lots of homework. So this is your first homework assignment. I want you to practice that mindfulness technique at your next meal. And if you're a little uncertain of how to do it, just look it up. You can Google it and you'll get lots and lots of descriptions and scripts for it, or you can download an app and practice it. So, and that will help keep you in the present moment. Another reason that we feel anxious at times is that we catastrophize. We make mountains out of the proverbial molehills in life. And, and I think we all have had that experience at times when, you ask ourselves, why was I so worked up over that? You would get worried about something or upset about something. And I was working with someone a while ago, a person with MS, and she came into my office and said, oh my God, I'm so upset by what's happening, at work. And I looked at her and I asked her, how important is this going to be to you, this work problem, 5 years from now? And she looked up at me and said, Dr. Foley, I'm not even going to remember it a year from now or 6 months from now. So if that's the case, why do you have to get so upset about it? Just asking that question. This is your next homework assignment. I want you to ask yourself the question the next time you're worked up over something, you're upset about something, you're very anxious about something. Ask yourself that question. How important is this really going to be to you 5 years from now? Because sometimes that can help put things in perspective. Will it work every time? Well, nothing really works every time, but it could, if you practice that, it could help you reduce your anxiety and teach you when you're overblowing things in your mind's eye, when you're making yourself more anxious than you need to be. So the next time you're anxious, I want you to also ask yourself, well, what is the bad thing you're expecting to happen in the future? Because that will be associated, almost always with anxiety. And then evaluate that expectation. Is it realistic? Are you overblowing something? Most people, when they're anxious about something in the future, have already psychologically transported themselves to that future, that negative outcome, and can't cope with it. Well, of course you can't cope with it because it hasn't happened yet. But what happens in reality is when negative things happen, we learn how to cope with it. So part of that anxiety is you've transported yourself into the future. Bad thing has happened. You don't know what to do about it. You can't cope with it. But that's all unrealistic, because you're not there yet. And it may never happen. And even if it does, you will learn how to cope with it. Okay. Anyone in the audience ever feel angry at times or irritable? Again, another universal human emotion. And anger is also about your expectations. Anger is the feeling that you feel when you expect or want something, you're not getting it, but you still expect or want it. So I want you to think about that, for a moment. So anger is also about your expectations and your wants. So, you're not getting it, you still expect or want it. I was working with one person with MS, who would get angry every time she got home from work. And I'd ask her, how come you're getting angry at your front door every time? And she said, well, my hand shakes when I'm trying to put the key in the lock. It takes me longer now to unlock my door than it used to. So I asked her, and again, this is in the context of a longer psychotherapy session, but what's relevant for the cognitive behavior therapy piece of this is I asked her, so you're expecting to not have any hand tremor? Is that correct? And since you don't want it, you're expecting not to have it, every time you open your front door, you're aggravating yourself. So, I'm not suggesting you give up on fighting MS, of course, but what I'm suggesting is, if the hand tremor can't be treated more than it currently is by your healthcare team, then gracious acceptance will give you much more peace than allowing yourself to be irritated. I'm guilty of this too myself. When I was a young assistant professor and had to commute from New Jersey to Albert Einstein College of Medicine in the beautiful Bronx, New York, where I'm still on faculty in the Department of Neurology, I used to get aggravated at traffic, and one day I woke up after getting irritated most mornings for the first month of my tenure there. And I started laughing when I was in the car. I said, Fred, you're a psychologist. You're expecting the busiest bridge in the country and the busiest highway in the country to be open and free for you, to have this wonderful, peaceful commute every day. And I laughed at myself because I was being so unrealistic. And I realized my expectations were, of wanting traffic to be light, and I wasn't getting it, and I still expected or wanted it. That's what was making me angry or irritable. My expectations were wildly out of sync with reality. And once I accepted that, I've almost never been irritated in traffic ever since, all these many years. I expect people to cut me off. I expect people to near miss me. I expect there to be accidents in traffic and all hell to break loose on the roads every day. And since I expect that, it doesn't bother me anymore because my expectations now match reality. So this is your next homework assignment. See, you didn't know you were getting cognitive behavior therapy here, did you? Well, you're getting it. So, so this is your next homework assignment. If you're chronically irritated by something or someone, I want you to identify what you're expecting or wanting you're not getting and that you still expect or want it. If you're expecting someone to change their personality, for instance, boy, are you going to be disappointed because that doesn't happen all that often. So I want you to evaluate your expectations and see, were you being as irrational as I was when I was expecting traffic in this very busy corridor to be free and light for me? So that is your next homework assignment, because anger and irritation are frequently, part of both depression and anxiety. And by reducing that, and particularly things that you're chronically irritated with, like my patient who was irritated every single day she came home from work because she couldn't get the key in the door as fast as she formerly could. So if there's something that you're chronically irritated about, that's important to identify. And that's important, really important for you to, probably adjust your expectations a little so that you'll be less irritated and annoyed. Okay, I frequently have people keep little diaries, and this is a cognitive behavioral diary that helps you analyze the thoughts associated with mood changes like depression and anxiety. First, I want you to record the situation. Who is present? What's taking place? And when and where does it occur? Kind of like a snapshot. So if you were taking a video of that moment, what would you see? The moment you get stressed. And then what thoughts did you have exactly at that moment in time? What went through your head? What ideas did you have? What expectations did you have? What images were there? And then how did that make you feel? What was the what would be a descriptor of your mood, like just a one-word descriptor? Happy, sad, irritated, angry, depressed, guilty, etc. And what were you feeling physically at that moment? So by keeping a diary like this, and I'll just give you one example out of one of hundreds of diaries of MS patients that I've had. This is just one example. This is the way it kind of looks. So who was present, what took place, and when and where did the stressful moment occur? And he said, I was by myself trying to get my work done because I'm taking tomorrow off. It happened Thursday just before lunch at my office. Thoughts at that moment in time. I'll never be able to get all this work done in time. I feel so fatigued. What's the use of trying to finish this? Why did this? And he meant the MS. Why did this MS have to happen to me? And he felt nervous and demoralized. And what was his behavior? Just sitting at his desk, staring off into space. Physically, he felt fatigue, sweaty palms, and his heart was beating fast. So this is the thoughts. This is the things that we want to work with from cognitive behavior therapy. Are his thoughts, do they need any adjustments? Are there any unrealistic expectations in there, that are contributing to his anxiety and demoralization? Does he need to adjust them, to get less work done because of his fatigue, perhaps? Or are there some other ways that he can problem solve or cope with it? So by doing this kind of self-analysis, you'll be better able to identify your thinking processes that are associated with depression, anxiety, or mood states that you're not liking very much at the moment. I would just like to ask, what time are we going to this evening?
We're going to 6:30.
To
Sorry, 7:30.
7:30. Okay, very good. Thank you for reminding me, Sheree. Okay, and we'll allow like 15 minutes for questions. Is that what we do? Okay, good. Now, thinking changes in a state of clinical depression in particular ways. You feel you have negative views of yourself, other people, the future, and the world. And these negative perceptions and beliefs are frequently distorted. They're exaggerated or inaccurate. To have a normal mood, we need kind of our central nervous system to be balanced in certain ways. When people are depressed, and I ask them, I want you to remember and feel a happy memory right now. Most of the time they can't do it. Those happy pathways in the brain are now closed off, so that, and then a few months later, when they're not depressed, they can remember lots of happy memories and feel the positive emotions associated with it. So if you're clinically depressed and someone says, think of something happy, just know to yourself, those paths are closed. You're not going to be able to do it very well. So don't get frustrated with yourself if you can't. So clinical depression is a state of intense emotional pain. So, I had a lesson from my father in what clinical depression can do to somebody. He was in his 70s, and at this point he was dying from metastatic cancer when he was 71 years old. And he used to be a very happy guy. He'd wake up and always look forward to something in life in spite of his cancer and the physical limitations that he now had because of it. So he called me up one day. I happened to be teaching in the Bronx at Einstein that day. And he said, Fred, you got to come over right away. Something terrible's happened to me. And then he hung up. I had no idea what was going on. I kind of raced over there, and he was kind of in the living room sitting by himself. And I said, Dad, what's wrong? He said, Fred, I feel sad kind of pretty much all day long. And I've been feeling this way for weeks. And I have no interest in life anymore. I'm not, normally I'm interested in something every day. I was interested in the news. I was interested in playing cards. I don't want to do anything. I've lost interest in everything. And I looked at him after he describes some more of his symptoms to me. I said, Dad, you have a clinical depression. He said, what's that? I said, that's what all these symptoms are that you're experiencing. They said, Fred, I can take the pain from bone cancer any day, but this clinical depression is the worst thing that ever happened to me. It has sucked, my feeling of wanting to live right away from me. And so I said, all right, Dad, we'll take good care of you. So we took good care of him. A couple months later, he was feeling much better and laughing and telling jokes and enjoying life every day again. So the lesson here is that depression is a state of intense pain, but it's treatable. And that's important to remember, because when people are depressed, they frequently don't seek out help because they feel hopeless about everything. But that's just a symptom of depression that's getting in your way. So, so if you are feeling that way, please, reach out, kind of be proactive, um, get help from your healthcare team. And if your current healthcare team isn't helping you adequately, then seek out a specialist, who can provide you with kind of more appropriate treatment. Okay. Now, in terms of managing mood, there are other things that you can do. You know what? And I'm going to give you, how would you like a little lesson in meditation? Because it's found to be helpful for both depression and anxiety. So, and I developed this approach for persons with MS because it's a mix of different meditative approaches. Because some patients, if they have attention concentration problems, well, you can't try to teach them concentration meditation, it'll just frustrate the heck out of them. Or if they have other symptoms, so I kind of have this little hybrid approach I developed so that most people with MS could get something out of it. Okay, so now I am going to ask you during this meditation exercise to take slow, deep breaths. Now, there's a way of breathing that stimulates parasympathetic nervous system activity in the body to relax you. Have you ever known anyone who's a stress eater? They get stressed out and they kind of raid the fridge. Well, there's a reason why we stress eat, is because as soon as you eat something, digestion begins, and a whole series of metabolic and hormonal changes occur when digestion begins to stimulate the parasympathetic nervous system, the relaxation arm of the nervous system. But you don't have to eat something, to be able to de-stress. You can breathe in this particular way that I'm going to describe to you. And it's not rocket science. All you have to do is make sure when you're taking a slow, deep breath that your exhalation is about twice as long as your inhalation. And I do this, and I practice this myself, because believe it or not, I get stressed out too. I'm as human as anybody else. So, and the way I do it is I inhale slowly through my nose, really stretching my diaphragm and abdomen out. And then I exhale slowly through slightly pursed lips so I can control my rate of exhalation. Other people do it by just counting in their heads. Inhale, 1, 2, 3, 4, hold your breath, 5, 6, 7, exhale, 8, 9, 10, 11. So however you're going to do it, I want you to practice this with me right now. I want you to take 3 slow, deep breaths, assuming that you have no medical contraindications for taking a deep breath. Probably most of you in the audience are breathing, so it's probably okay for you to kind of breathe in a little more deeply. Okay. All right. So let's do this now. Take 3 slow, deep breaths. And then just breathe at whatever is a comfortable rate for you. Now, I want you to notice, is your body slightly more relaxed having done that? I know mine is. But I've been practicing this a long time. But this is your next homework assignment. And I am going to be testing you all later. So I want to make sure you do your homework. I want you to practice breathing in this way several times a day. I mean, you're breathing all day anyway. You might as well breathe in a way that will train your parasympathetic nervous system to come online and help distress you when you need it. So practice this, breathing, making sure your exhalation's twice as long as your inhalation. Okay, that's the first thing about meditation, is breathing in that way. Second thing about meditation is your mind is going to be distracted towards it, when you're doing it. Even we're going to practicing this for like about 5 minutes, but you'll be distracted. Noises will distract you. The sound of my voice will distract you. Things moving around in your room, and just worries or concerns may pop into your mind. Do not be concerned by any distractions. Welcome them even. Just take note of each distraction as it occurs and kind of process that, saying, oh, yep, the sound of his voice distracted me. Oh, there's that worry again, distracted me. So don't be concerned, just take note of each one and then gently return your attention back to the meditation exercise. Next thing about meditation is it's important for you not to have your arms or your legs crossed, during meditation. And the reason for that is the meditation, stimulates peripheral vasodilation. And you don't want to put pressure on your vasculature that will inhibit that process. That's part of the relaxation process. Okay. And the other thing to remember about it is only about 80% of people like it. 20% of people don't, and that's fine. Because we're not machines, we're human beings, and there's not one size fits all, and not one approach to managing anxiety or stress is going to work for everybody. You'll all have to find your own pathways for that. Okay, now let's practice this little meditation exercise I'm going to teach you how to do. I'd like you to begin by getting comfortable, kind of stretching your muscles a little bit. Don't stretch them in a way that'll give you a spasm or anything, but just stretch them. You're going to roll your shoulders if you can. Stretch your arms, your legs, because that facilitates the body relaxing. Now, I would like you to close your eyes and take 3 slow, deep breaths in the way that we described, making sure your exhalation is around twice as long as your inhalation. And then just breathe at whatever a comfortable rate, a comfortable rhythm for you. I'd like you to begin by focusing on the muscles of your body. Start with the muscles in your forehead and scalp. Picture them becoming smooth as you allow the muscles in your forehead and scalp to relax. Picture the relaxation flowing down into the muscles of your eyelids as you allow the muscles in your eyelids to relax just a little bit more. It will almost feel as if they're getting heavier and heavier, more and more relaxed. Imagine the relaxation flowing down into the muscles of your jaw, a place where we hold so much tension at times. Allow the muscles of your jaw to become more limp, more loose, just a little bit more relaxed. Picture the relaxation flowing down into the muscles of your shoulders and arms. See if you can drop your shoulders a little bit more as you allow those muscles to relax more deeply. Picture the relaxation flowing down your arms, into your hands, and even your fingers, a little bit more relaxed. Take another slow, deep breath in the way we described. Really expand the muscles of your abdomen, diaphragm, and chest, allowing them to relax more deeply. Picture the relaxation flowing down your back, to your lower back, to your lower body, your legs and feet. And as you're beginning to allow your body to relax a little bit more, I would like you to notice the natural relaxation that comes with the breathing cycle. Notice that each time you begin to exhale, there's a natural letting go that takes place in the body, a subtle relaxation effect. So focus on your breathing now. And every time you begin to exhale, say the word one silently to yourselves each time you exhale. There will be many distractions from keeping your muscles relaxed. Saying the word one silently to yourselves each time you exhale. Do not be concerned by any distractions. Simply take note of them. And then, once again, return your focus to your breathing cycle. I'm just going to allow you to practice this quietly for 1 minute. And once again, I would like you to take very slow and very deep breath, allowing your exhalation to be twice as long as your inhalation. Now, I'm going to count backwards from 5 to 1. And as I do so, you will allow yourselves to feel increasingly refreshed, relaxed, yet alert. 5, 4, 3, eyes open, 2, 1, refreshed, relaxed, and alert. So that's all there is to it. And there are lots of meditation apps out there. There haven't been kind of studies on brain structure and function in MS with meditation. But in the general population, regular meditation practice has been found to increase the cortical thickness of the hippocampus, which is the area in the brain involved in learning and memory, and also in the prefrontal cortex, which is associated with attention, concentration, and executive function. Okay, it is time now for questions, and I hope you're all a little bit more relaxed.
Thank you, Dr. Foley. If you have a question or comment, feel free to type it into the Q&A or into the chat box. If you wish to ask your question in person, feel free to raise your hand and I will call on you when we get your place in line. I currently have several questions in the Q&A that have been popping in since the beginning, and I already see at least one hand up. So let's get started. Also, if you're on Facebook and you want to ask a question, type it into the Facebook Live comment section, and we will ask that. We do have, our first question is from Lisa on Facebook, and she asks if there's any data as to how many people with MS have increased depression when treated with antidepressants.
Okay, there is some data on that, and my clinical observations are that sometimes the first antidepressant you're prescribed, and physicians want to prescribe it at generally low doses initially to see how you react to it, so you don't have untoward side effects or things like that. But in my experience, you have to up the dose, pretty high, and sometimes use a couple of different antidepressant agents in MS to significantly help with those symptoms. Also, since cognitive behavior psychotherapy has been found to be helpful for depression and anxiety with MS, if you wanted to hit a home run, get some medication and take some cognitive behavior psychotherapy for it and learn meditation. And don't forget to breathe in the way that we describe.
Thank you. Jamie wants to know, is inflammation in the central nervous system a correlation to depression or something that we have seen that affects actual brain chemistry?
So,
Dr. Foley, you have just frozen.
Frozen? Am I back yet?
You're back.
Okay. All right. So, inflammation in the body is very important because, it's our immune system that keeps us alive and kind of keeps us from dying from pathogens. But there are times when you can have too much inflammation, like in the central nervous system with MS, where myelin products are targeted, accidentally and inadvertently. And also, depression is associated with kind of general inflammation in the body, particularly, certain type of more general inflammation. It's not MS-related inflammation, but it's just general inflammation that depression kind of helps trigger in the body.
Okay. We have an anonymous attendee saying, I've tried psychoanalysis for 5 years or so, CBT for the last 3 years, and Zoloft for the last 6 months, and every day I'm more depressed. Any suggestions?
You really need a consultation from a good specialist because you have treatment-resistant depression. You've tried, an antidepressant that is frequently effective. You've tried different types of psychotherapy. The literature strongly supports CBT in MS, and you're not responding to that. So, you're going to kind of need more aggressive treatment. I would strongly suggest you see a psychopharmacologist, to work with, getting on other meds besides the Zoloft for the depression. Also, the other thing that happens when you're on antidepressants, if you're on them for a long time, what happens frequently is they become less effective. The liver is smart, and the liver recognizes kind of antidepressants that have been traveling through it, for a long period of time. So after a few years, antidepressants frequently become less effective, and you got to switch them up or increase the dose or change things. So if you've been on the same dose of Zoloft for a long time, it may be that you have a smart liver and it's not allowing it to be effective.
Thank you. And another anonymous attendee says, would you recommend some sort of somatic therapy for MS or EMDR, even if I don't suffer from PTSD?
Well, you're right. EMDR was developed and tested for PTSD originally, and it's been tried in a lot of different psychological conditions. There's just no evidence. I haven't read a clinical trial of EMDR and MS, so I don't know how well or how well not it would work in MS. I would think if you have MS and you have PTSD, since that's what EMDR targets, then it would probably be effective for the PTSD symptoms. But I don't know if it would be for depression.
Another anonymous attendee says, does depression decrease overall brain activity? And if so, the less you use of your brain cells, will they end up dying off?
Okay, it's a good question. Depression does not kill your brain cells. So that's one thing that you can take off your worry list, is that if you're depressed, even chronically, it's not going to kill your brain cells. It'll make you miserable, and kind of impair your emotional functioning. And it kind of really interferes in quality of life, but that's pretty much what it does. It's not biologically toxic to the central nervous system.
Jamie mentions that in the episode of the patient who was going through a depressive episode, you mentioned that the neural pathways are closed off, being able to recall happy memories. Is this a physical or a chemical reaction? Can you speak more on the chemical functionality behind that?
Okay. I can't speak more on the chemical functionality for it. As a clinician, I've simply observed this time and time again in patients with clinical depression. If I was able to do, there have been some fMRI studies, functional magnetic resonance imaging studies of non-MS patients who were clinically depressed. And what it found is the areas in the central nervous system associated with pleasure were not active in patients who were depressed compared to non-depressed matched controls. And these are dopaminergic pathways. So I guess I can speak somewhat to the chemistry of it. And so the dopaminergic pathways are associated with pleasure. They're also associated with addiction. And in depression, they get quieter, which is probably the biological underpinning of why it's hard to feel pleasure or remember happy things.
Another anonymous attendee asks for advice on cannabis for anxiety.
Boy, is that a loaded question. So again, cannabis use, some people say it's wonderful for their anxiety, but sometimes it causes anxiety and can worsen anxiety. And it's also, if you use it every day, you can build tolerance to it so that you need more and more of it over time to get the same effect that you like to get from it. So cannabis is kind of a mixed bag. I would just discuss it with your healthcare provider and give it a shot and see if it works for you. Assuming you're acquiring it legally, and assuming you're acquiring it from a respectable, a place where they do laboratory studies and it's uncontaminated. So I would never recommend anyone taking cannabis that wasn't, from a legal, respectable, lab-oriented place.
Judy also has her hand up, but she typed this into the Q&A. Are there any online CBD or CBT courses you recommend? And Judy, if I'm going to lower your hand, and if you want to just go ahead, if you still have a question, re-raise your hand again. So online CBT courses.
I'm not aware of any, but, I would recommend you Google it and see, if you can kind of audit one or take one. I used to teach CBT for years, at the university. So CBT is taught in every graduate psychology program practically in the country. I'm sure there's lots of books on CBT. There's books for lay people on CBT. So, there's self-help books on it. So there's a lot of information out there. I don't have anything specific that comes to the front of my mind, but if you search, you will find it.
Rob has his hand up, and if you would just want to unmute yourself, Rob, and ask your question.
Yes, hi. Thank you. I'm really getting a lot out of this. I had a question, actually, two questions and a comment. First comment is that I use cannabis not so much for anxiety, but for muscle spasms, and I find it helpful for that. Second thing I was wondering is, you mentioned when people are on antidepressants, a particular antidepressant, for a while, it starts to become less effective. Is there, what would you say is the drug that is closest to Prozac for that type of situation? And I'm just asking you, obviously, in a general sense, not for your specific medical recommendation. And then finally, for years, the model seems to be that you go to one place for medication and that person checks in with you for 15 minutes, and you go to another for therapy. And that always seemed to me to be kind of disconnected or not holistic. And I was wondering what your opinion of that is. Thank you.
You're welcome. In terms of kind of antidepressants close to Prozac, I mean, it's part of a whole class of antidepressants called the selective serotonin reuptake inhibitors. There are half a dozen of them in that class. Some of them are a little more sedating. Prozac is a little more activating than sedating. So, again, I would discuss, that class of meds with your prescriber. If you're not satisfied with the Prozac anymore, or you feel the Prozac has been working less, currently than it had been if you've been on it for a while, just discuss that with your healthcare provider. Sometimes they don't switch you off it. Sometimes they just increase the dose, and see if that works. Or sometimes they won't take you off it, but add something as a secondary to it. And sometimes they'll decide to take you off it. But those are individual clinical decisions that have to be individualized to each person, based on their medical and emotional history and all the other meds and conditions that they might have to deal with.
Dr.
Okay,
Foley,
yeah.
We're at 7:30 right now. Do you have a few minutes to take the last few questions, or no?
Sure. My calendar is completely free tonight, so I'm happy to stay if, and answer people's questions.
All right, we have an anonymous attendee asking if you could speak broadly to the mindset of antidepressants. This individual went on one and didn't like it, and as a result, they're highly reticent to ever go on another one. Is that a mindset to just get over?
Well, unfortunately, prescribing antidepressants is completely hit and miss. In the future, we'll genetically know who is likely to respond best to what kind of antidepressant. But right now it's hit and miss. And it's a long, painstaking process. First, your healthcare prescriber has to prescribe you the initial antidepressant and at a relatively low dose. Then you have to wait a month because it takes a month to see if it's working. And then if it's not working, well, then they have to up the dose, and you might have to go through several cycles of that. And also keeping track of side effects, and other things. You mentioned you didn't like it. So that was an antidepressant that probably had negative side effects for you, which you should definitely bring up with your healthcare provider and then say, I want an antidepressant that's not going to do this to me. So it's not going to give me those side effects. So I would recommend that you don't give up unless you're not feeling depressed anymore. But if you're still feeling depressed, I wouldn't recommend that you give up. I would recommend that you go back and just, unfortunately, it's a trial and error process. It takes months frequently to get the formulation right. Sometimes it takes up to a year to get it right. As you're kind of slowly increasing doses, checking in a month, trying other things. But, most of the time you can get the formula right, if you're patient and can tolerate it. So I would just encourage you to kind of keep at it.
Thank you. Jamie wants to know if the demyelination of neurons has a direct influence on the likeliness or severity of developing depression or worsening of pre-existing depression.
Yes. There have been regional structural brain studies that have been done that found that 47% of the depression severity in MS is associated with brain lesions in particular areas. But just because, a brain lesion could be contributing a great deal to the onset of depression or worsening depression, we know from the literature they can still be successfully treated. As I said before, they have to be vigorously treated in MS frequently, more so than in the general population, in order to achieve a maximum, effect. But and that's why I encourage you all to not to give up and to keep at it and to remember to breathe, in the way that I described, practicing that, identifying your expectations, either negative outcomes in the future, and kind of doing that little exercise to decrease that. And if you find yourself chronically irritated by something, again, what are you expecting or wanting that you're not getting, but you still expect or want it? Do you have unrealistic expectations, as I do as a human being at times?
We have Paulette from Facebook asking, said she was on Zoloft for 16 years. It had to be increased from 25 to 125 milligrams when she was diagnosed with MS. And is this common? And I think you touched on that with the fact that our livers can be smart and things can become less effective over time. But I think she's relating to the fact that it had to be increased when she got her diagnosis.
Yes. As we said before, we know that the MS itself, can contribute significantly to depression and depression severity. So it sounds like you did your job. You complained to your healthcare provider saying, I'm more depressed since this MS, do something about it. And it sounds like they helped you out. So hopefully that increase in Zoloft helped you. If you don't have an adequate response, just please keep at it.
Okay. Rob is typing into the Q&A box. If you have time, could you please answer the question that I asked about the interplay of therapy and the medication provider or prescriber? It seems not to be very holistic.
I knew there was a second part to your question and comment, but it escaped my brain at the moment. My apologies. So the reason that psychiatrists used to do psychotherapy, but you're right. Most of the people who prescribe, whether it's a psychiatrist, psychiatric nurse practitioner, or in some states in the United States, psychologists. It's unfortunate, but you make a lot more money for a 15-minute medication session than you do for a 45-minute psychotherapy session. So the underlying economic pressures have separated out most practitioners who prescribe to leaving the psychotherapy part to professionals that don't prescribe. Now, sometimes you can find a provider who will do both, but in my experience these days, it's rare because of those underlying economic pressures.
We have 4 more questions in the Q&A, but they tend to be somewhat complex questions, and I don't think that they can be answered in a minute or less. So what I would ask the four of you to do is, if your questions have not been answered by the talk or in the Q&A portion of this talk, if you would please type them into a response to your registration email for this event. And we will forward those to Dr. Foley and see if we can't get you some answers to your questions. And I think that brings us to the end of our time. If you missed any part of this conference, it has been recorded and we will be available through the MS Focus Facebook page. It'll also be posted on our YouTube channel as well in about a week. Again, reply to your registration email for access to recordings or to sign up for our newsletter and to learn about future events. Our next conference will be this coming Thursday, February 9th at 5 p.m. Eastern Time, and it will feature Dr. Terry Walls discussing dietary research and the findings which may relate to MS. As you leave the conference today, please stay on the line for a brief survey that will appear on your screen. We welcome your input on our program content and topics you would like to see addressed at upcoming events. And I want to thank Dr. Foley for being here today and for giving so generously of his time and expertise. Thank you.
Thank you so much, Sherry. Okay. Good night, everybody.
Good night.